Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled What's New? Novel Agents for the Management of Gram-Positive and Gram-Negative Bacterial Infections. Following the webinar, please be sure to follow the instructions alongside this webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free North Carolina CE credit. Our speakers today are Kendall Tucker, who's currently a PGY2 infectious diseases resident with Novant Health Forsyth Medical Center in Winston-Salem. He received his Doctor of Pharmacy from South Carolina College of Pharmacy and completed his PGY1 training at the University of New Mexico. Chelsea Huang is currently a PGY2 infectious disease resident with Novant Health Presbyterian Medical Center in Charlotte. She received her Doctor of Pharmacy from Jefferson College of Pharmacy and completed her PGY1 training at Penn Presbyterian Medical Center. I will now turn it over to our first speaker, Dr. Kendall Tucker.
Hello, this is Kendall Tucker, PGY2 resident in infectious diseases at Novant Health Forsyth Medical Center. Today we'll be talking about what's new, novel agents for the management of gram-negative and gram-positive bacterial infections. As presenters, we have no conflicts of interest and no financial interest in any of the companies, products, or services mentioned in this programs, and no other things to disclose. As part of our objectives today for the first half of this presentation, we will be discussing the need for antimicrobial agents for gram-negative pathogens, identifying and describing newly approved antimicrobial agents for the treatment of gram-negative infections, and delineating potential roles for new agents in the management of gram-negative infections. When looking at the past several decades of antibacterial agent approval in the United States, the number of agent approvals over the previous years have gone down with each additional year. There were as many as 16 antibacterial agents approved between the period of 1983 and 1987, but when looking at the period between 1998 and 2004, there were as few as 5 new agents approved for the management of antibacterial infections. The World Health Organization has recognized antibiotic resistance as one of the 3 greatest threats to global health. This lack of new agent approval is particularly concerning because of this major threat to public health that's been recognized, and at least 2 million people are infected with antibiotic-resistant bacteria in the United States each year, and bacteria are responsible for an estimated 160,000 deaths annually. In 2004, the Infectious Diseases Society of America report, Bad Bugs, No Drugs, voiced concern over these lack of agents to treat drug-resistant infections. A 2008 article published by Rice et al. Recognized escape pathogens as the cause of the majority of hospital infections, and these organisms were of particular concern because of their ability to effectively escape from antibacterial agents. When specifically reviewing these escape pathogens, 4 of the recognized pathogens are gram-negative organisms. In recognition of these organisms, in 2009, the IDSA released an update to that 2004 report regarding the development of new agents, and they still expressed concern over the lack of agents targeting these drug-resistant pathogens. So when we look at the period of time between 2005 and 2009, covering that period after the release of the 2004 IDSA report, there are only 2 new agents that were FDA approved for coverage against gram-negative organisms, those agents being tigecycline and doropenem. To this end, the IDSA still expressed concern over the approval of new agents and called for this initiative, the 10x20 initiative, which called for the development of 10 new antibiotics by 2020 to specifically target escape pathogens and multi-drug resistant organisms. The purpose of this first half of the presentation will be to specifically provide an overview of new agents that have been developed and approved for the targeting of gram-negative pathogens. So prior to reviewing the antimicrobial agents, there are some standard definitions that may be utilized throughout this presentation. And specifically looking at these definitions, multi-drug resistant organisms, or MDR, are acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. Extensively drug-resistant organisms, or XDR, is non-susceptibility to at least one agent in all but 2 or fewer antimicrobial categories. Pan-drug resistance, or PDR, is non-susceptibility to all agents in all antimicrobial categories. These are the organisms that these new agents have specifically been targeting, and of which new agents are still desperately needed, especially in the case of organisms that are extensively drug resistant and pan-drug resistant, which will require the development of novel antimicrobial classes. I'd also like to discuss some mechanisms of resistance that may be discussed within this presentation. Extended spectrum beta-lactamases, or ESBLs, are enzymes that confer resistance to a broad range of beta-lactam antibiotics. These organisms remain susceptible to carbapenems and some beta-lactamase inhibitor combinations. Carbapenem resistance, or CR, are organisms that express carbapenem resistance. However, this does not always entail the production of carbapenemase enzymes. Klebsiella pneumoniae carbapenemases, or KPCs, are the most prevalent mechanism of carbapenemase resistance in the United States and can be found in several other gram-negative bacteria and is not specific only to Klebsiella. Of note, Klebsiella pneumoniae carbapenemases were initially discovered in North Carolina. And also of note, in terms of carbapenemase coverage, for the purposes of this presentation, we will be referencing primarily KPCs, and it can be assumed that production of KPC is what is being discussed unless otherwise specifically stated. So how have we done in approval of new agents for the production of gram-negative organisms? Between the period of 2014 and 2018, there were 5 new antimicrobial agents that were approved targeting resistant gram-negative pathogens. So the agents that are listed here, first with approval in 2014, is Zerbaxa, or ceftolozane tazobactam, which is an anti-Pseudomonas cephalosporin plus a beta-lactamase inhibitor combination. Avicaz, or ceftazidime avibactam, was approved in 2015, is an anti-Pseudomonas cephalosporin, and includes a novel beta-lactamase inhibitor combination. Babomir, or meropenem vaborbactam, was approved in 2017 and includes a carbapenem antibiotic plus a boronic acid beta-lactamase inhibitor. Zimdri, or plazomicin, was also approved in 2017 and is an aminoglycoside antibiotic with resistance against aminoglycoside modifying enzymes. Xerava, or ravacycline, is a fluorocycline antibiotic that was approved in 2018 and is a synthetic tetracycline derivative. With our first agent, Zerbaxa, against ceftolozane tazobactam, is a combination product of ceftolozane and tazobactam. Ceftolozane is a cephalosporin antibiotic with anti-Pseudomonas activity that has a similar structure to ceftazidime with greater activity against Pseudomonas. Ceftazidime may be less impacted by the overexpression of efflux pumps, leading to this greater activity against Pseudomonas. Also of note, ceftolozane is active against AMP-C production. However, it is weak against ESBL production and carbapenemases. Tazobactam, the beta-lactamase inhibitor, restores activity of ceftolozane against some classes of ESBLs. However, it does not restore activity against carbapenemases. Ceftolozane tazobactam does have FDA approvals for complicated intra-abdominal infections when used in combination with metronidazole and pyelonephritis, and then also complicated urinary tract infections, again in combination with metronidazole. We've also recently received FDA approval for treatment of hospital-acquired pneumonia and ventilator-associated pneumonia. When specifically looking at the spectrum of activity of ceftolozane tazobactam, it has broad gram-negative activity and also coverage against ESBL-producing Enterobacteriaceae. when specifically thinking about the clinical utility of this agent, really the enhanced coverage against Pseudomonas aeruginosa is of note with ceftolozane tazobactam, in part due to its ability to cover ceftazidime and carbapenem-resistant Pseudomonas due to non-carbapenemase producing mechanisms such as that overproduction of efflux pumps, of which ceftolozane is protected against. Areas where coverage gaps exist include carbapenemase producing Enterobacteriaceae, gram-positive organisms, and anaerobes, and also against Acinetobacter species of which it has no activity. In terms of dosing recommendations, there are renal dosing adjustments that should be made in patients being treated with ceftolozane tazobactam, and as can be shown by the table here, the renal adjustments in dosing does differ between intra-abdominal infection, UTI, pyelonephritis, and the dosing regimen that would be used for treatment of hospital-associated pneumonia and ventilator-associated pneumonia, again as shown by the table here. In terms of the clinical utility of ceftolozane tazobactam, Sater et al. Evaluated its in vitro activity against the randomized cohort of Pseudomonas aeruginosa isolates across 70 U.S. medical centers. When comparing the agent ceftolozane tazobactam against other beta-lactam antibiotics, it was the most active in vitro antibiotic across this cohort at 97.5%, really highlighting the stability of the combination antibiotic against Pseudomonas resistance mechanisms. When specifically looking at isolates that were non-susceptible to other anti-Pseudomonas beta-lactams, specifically cefepime, meropenem, and piperacillin tazobactam, ceftolozane tazobactam retained much greater activity against resistant isolates in comparison to ceftazidime avibactam at 78.7% and 70.2% respectively. Gallagher et al. Also evaluated ceftolozane tazobactam against multi-drug resistant Pseudomonas aeruginosa, and this study found similar results in that ceftolozane tazobactam expressed the greatest activity against multi-drug resistant Pseudomonas when compared to other agents, with the only exception being colistin, which showed a susceptibility pattern of 91.9%. And so again, really highlighting that ceftolozane tazobactam is a drug really indicated for use against multi-drug resistant Pseudomonas aeruginosa in terms of clinical utility. Ceftazidime avibactam, or Avicaz, is a combination antibiotic that involves a third-generation cephalosporin, ceftazidime, which has anti-Pseudomonal activity, in combination with avibactam, which is a novel non-beta-lactam beta-lactamase inhibitor that restores activity against ESBL and also against Klebsiella pneumoniae carbapenemases. Ceftazidime avibactam has FDA indication approvals against complicated intra-abdominal infection in combination with metronidazole, pyelonephritis, complicated urinary tract infection, again in combination with metronidazole, and also approval against hospital-acquired pneumonia and ventilator-associated pneumonia. Ceftazidime avibactam has broad gram-negative activity and also coverage against Pseudomonas aeruginosa. However, the real clinical utility of this agent is its activity against carbapenemases, specifically Klebsiella-producing Klebsiella pneumoniae carbapenemases. And it does have coverage gaps against gram-positive organisms and anaerobes, and also it does not cover Acinetobacter species. The dosing recommendations are listed below. There are dosing recommendations for patients with renal dysfunction, and of note, dosing is similar between all indications, including hospital-acquired pneumonia and pyelonephritis. And so, again, that's noted here within the table. And so, when evaluating the clinical utility of ceftazidime avibactam, it was evaluated against Enterobacteriaceae across 70 medical centers by Sater et al. And what this show for in vitro activity is that it had broad activity against these Enterobacteriaceae and covered 99.9% of all organisms. It's important to note that in comparison to ceftolozane tazobactam and piperacillin tazobactam, ceftazidime avibactam retained activity against 97.5% of all CRE isolates. There are also studies comparing ceftazidime avibactam against colistin for use against carbapenemase-resistant Enterobacteriaceae. And what these studies evaluating this showed was that there was possible benefit over colistin for treatment of CRE infections. This first study, conducted by Shields et al., found that ceftazidime avibactam use was associated with a lower 30-day mortality and a statistically significant difference in 90-day mortality. A second study conducted by Van Duyn et al. Found that colistin had a 32% 30-day mortality, which is much higher than the 9% 30-day mortality in comparison to ceftazidime avibactam. However, what should be noted from these studies is that they were single-center studies with small sample sizes. However, this data is very promising for the use of ceftazidime avibactam against CRE in comparison to other available agents that would be used for treatment of CRE infection. Meropenem-vaborbactam, or Vabomere, is a combination antibiotic that combines meropenem, an anti-pseudomonal carbapenem, with broad activity against gram-negatives, including ESBLs, with Vabomere, which is a novel boronic acid beta-lactamase inhibitor that again increases this activity against ESBLs and also restores activity against Klebsiella pneumoniae carbapenemases. Of note, Vabomere does not increase activity against Acinetobacter species or Pseudomonas aeruginosa, and specifically targets serine-based carbapenemases. Currently, meropenem-vaborbactam is only indicated for treatment of complicated urinary tract infection. However, we would see uses in potentially other disease states with resistant organisms. In terms of spectrum of activity, again, it has broad gram-negative coverage and also covers ESBL and KPC producing Enterobacteriaceae and also gram-negative anaerobes. Coverage gaps of meropenem-vaborbactam include carbapenem-resistant Acinetobacter species and also carbapenem-resistant Pseudomonas aeruginosa as well. And then it also includes carbapenem resistance due to non-class A carbapenemases. So that would be our carbapenemases that do not have these serine-based targets. And of note, it has no activity against metallo-beta-lactamases. Again, meropenem-vaborbactam does have dose adjustments necessary for renal dysfunction, and dosing recommendations can be found within the table listed below. So in terms of clinical utility, what this study here found was that meropenem-vaborbactam did have very good in vitro activity against KPC-producing Enterobacteriaceae. It's found to be non-inferior to ceftazidime avibactam. And then specifically when looking at cross-resistance between the two agents, of the 24 isolates that had resistance to at least one of the two agents, cross-resistance was relatively uncommon and only occurred in 5 isolates. So in patients that have resistance to ceftazidime avibactam, meropenem-vaborbactam may be another agent that may be used, or in patients who have developed resistance while on therapy with ceftazidime avibactam. Azomycin, or Zimdri, is a synthetically derived aminoglycoside antibiotic with resistance against aminoglycoside modifying enzymes. It's active against ESBLs and KPC-producing organisms, and it's currently indicated for treatment of complicated urinary tract infections and pyelonephritis. In terms of spectrum of activity, it maintains activity against resistant organisms compared to other aminoglycosides, and potential areas for use include ESBL and KPC-producing Enterobacteriaceae. Of note, plazomicin does lack coverage against anaerobes, Acinetobacter, and gram-positive organisms. In terms of dosing recommendations, therapeutic drug monitoring is required, and dosing adjustments should be made for renal dysfunction, and it's recommended that troughs should be maintained to be less than 3 micrograms per milliliter. And so this study, so in terms of clinical utility of plazomicin, there were two studies that evaluated its use. And so the EPIC trial evaluated plazomicin versus meropenem and found that plazomicin was non-inferior to meropenem for the treatment of complicated urinary tract infection. And then the CARE trial evaluated plazomicin versus colistin plus an additional agent, either being meropenem or tigecycline, for the treatment of carbapenem-resistant Enterobacteriaceae, and found that plazomicin was associated with a 14% 28-day mortality in comparison to 53% mortality in the comparator arm, suggesting possible superiority or clinical utility for the use of plazomicin over colistin plus an additional agent for the treatment of CRE infection. However, what should be noted is that the sample size in the study was small, and additional follow-up should be done to tease out true utility of plazomicin against CRE infection. Eravacycline is a fluorocycline synthetic tetracycline antibiotic with resistance against tetracycline efflux pumps and ribosomal modification. Approval trials of eravacycline found it to be very well tolerated, especially in comparison to newer tetracycline derivatives such as tigecycline. Currently, eravacycline is indicated for the treatment of complicated intra-abdominal infection, and trials evaluating eravacycline for treatment in urinary tract infection showed inferiority against levofloxacin. However, there are additional trials being conducted for use against urinary tract infection. In terms of dosing of eravacycline, this dosing and pharmacokinetic profile is very stable and at 1 milligram per kilogram Q12 IV, and no modifications are necessary for renal or liver dysfunction in patients being treated with eravacycline. The spectrum of activity includes gram-negative coverage, including ESBLs and Acinetobacter species, and eravacycline may also have coverage against carbapenemase-resistant Enterobacteriaceae and carbapenem-resistant Acinetobacter species. Of note, the particular coverage gap of eravacycline is used against Pseudomonas aeruginosa. And so the IGNITE-4 trial evaluated eravacycline against meropenem, against complicated intra-abdominal infection, that also included ESBL-producing organisms. And what it found was that the clinical cure rate between eravacycline and meropenem was non-inferior to meropenem in both all isolates and also in ESBL-producing organisms. Another trial by Livermore et al. Looked at in vitro susceptibility data of eravacycline and found that eravacycline was 2 to 4-fold more active against CRE and CR Acinetobacter species than tigecycline. Unfortunately, there are no breakpoints, and so this translation to clinical practice would require further study prior to broad use of eravacycline for the treatment of CRE or carbapenem-resistant Acinetobacter species. And so overall, there are new agents that have been approved for the treatment of resistant infections. As shown by the table here, we now have 5 new agents that provide coverage against ESBL-producing organisms, and 3 new agents that are providing coverage against our KPC-producing carbapenemases. And then there are 2 agents that have broad activity against carbapenem-resistant Pseudomonas species. What we still need is that none of these new agents provide broad coverage against all of these resistant organisms, and so it's important to know what we're getting with each of these organisms and what the coverage gaps exist when deciding on which agent to add to formulary and which agents we should use in clinical practice. We are still lacking agents for the coverage of carbapenem-resistant Acinetobacter species and then non-Klebsiella pneumoniae producing carbapenemases, and so additional antibiotics will need to be developed and additional studies need to be conducted evaluating the use of these particular agents in that particular arena. Of note, there are additional agents that are currently in development that we may see fill some of these coverage gaps. Imipenem relebactam cilastatin is a carbapenem antibiotic, again with the non-beta-lactam beta-lactamase inhibitor, and with broad activity against ESBL-producing gram-negatives, KPCs, and carbapenem-resistant Pseudomonas species as well. Cefiderocol is a siderophore cephalosporin that binds iron for transport into bacterial cells and has broad activity against gram-negatives, resistance to all classes of beta-lactamases, including ESBLs, KPCs, and notably metallo-beta-lactamases as well. H-treonam avibactam is a monobactam and a novel beta-lactamase inhibitor, avibactam, and it has broad activity against multi-drug resistant gram-negatives. However, of note, it does not broaden activity against Pseudomonas. And again, its coverage added is against ESBL producers, CREs, including KPCs and metallo-beta-lactamase producers. And so those were the new agents that have been developed for gram-negative organisms, and also some of the new agents that are currently in development for treatment of gram-negative organisms. And now I will turn it over to Chelsea to discuss gram-positive infections and new agents in development for those.
Hello, my name is Chelsea Huang. I'm the PGY2 ID pharmacy resident at Presbyterian Medical Center. And today I will be discussing some of the new agents for gram-positive infections. The objectives of my section is to discuss the need for antimicrobial agents for gram-positive pathogens, identify and describe newly approved antimicrobial agents for the treatment of gram-positive infections, and lastly, delineate potential roles for new agents in the management of gram-positive infections. As previously mentioned, the escape pathogens cause the majority of U.S. hospital infections and escape the mechanisms of action of our available antibiotics. Gram-positives are included on this list, and they are Enterococcus faecium and Staphylococcus aureus. The CDC has also conducted an assessment of antibiotic resistance threats and categorized them based on factors associated with resistant infections, including clinical impact, economic impact, and incidence. Notice two of these gram-positive infections with serious threat level are caused by escape organisms, Enterococcus and Staphylococcus aureus. Therefore, the development of antibiotics active against escape organisms is crucial in order to continue to provide optimal care for patients who are affected by these infections. When taking a look back at the approvals of gram-positive antibiotics, there was a period of steady approvals from penicillin to trimethoprim sulfamethoxazole, followed by an almost 30-year period without major gram-positive agents, until linezolid was approved in 2000. Most recently, ceftaroline, a MRSA-active cephalosporin, was approved almost a decade ago. Thankfully, recently we have had some new FDA approvals for gram-positive antibiotics and some promising antibiotics in the pipeline. The first new gram-positive antibiotic I will be discussing is delafloxacin, brand name Baxdela. Delafloxacin was approved in 2017. It is a novel fluoroquinolone that is chemically different than other agents in the same class. It does have the same mechanism as other fluoroquinolones, however has demonstrated similar potency for both topoisomerase 4 and DNA gyrase. Delafloxacin is available both IV and PO, and the FDA has approved the use of delafloxacin in acute bacterial skin and skin structure infection. Note the difference in dosing between IV and PO formulations, and doses do need to be adjusted for renal function. Delafloxacin has an anionic character at neutral pH, and in acidic conditions such as abscess fluid and decubitus ulcers, it actually exists in the neutral form, thus enhancing potency and intracellular penetration. Delafloxacin is a fluoroquinolone and therefore confers the warnings and boxed warnings that comes with fluoroquinolones. Most recently, the FDA released a warning regarding the risk of aortic aneurysm with fluoroquinolones. Common adverse effects from the clinical trials include gastrointestinal effects such as nausea and diarrhea, However, notably absent fluoroquinolone adverse effects for dialofloxacin include phototoxicity and QT prolongation. This chart is a summary of dialofloxacin's spectrum of activity. Green denotes active, while red denotes unlikely active. Dialofloxacin has better gram-positive activity than other fluoroquinolones, but has similar or less activity against gram-negatives compared to other fluoroquinolones. For example, it has less activity than ciprofloxacin and levofloxacin against Serratia and Citrobacter. Notably, it also has poor activity against Enterococcus faecium. Even for MRSA isolates, the susceptibility rates reported in studies are around 88%, which is a lower percentage of susceptibility than some of our more frequently used MRSA active agents like vancomycin. Additionally, dialofloxacin has demonstrated activity against gram-positive and gram-negative anaerobes and atypicals. The two phase 3 studies that led to dialofloxacin's approval are called PROCEED. These two studies are randomized, double-blind, non-inferiority studies with a 10% non-inferiority margin. Note that the design of subsequent trials discussed in this talk have similar design unless otherwise noted. The two PROCEED trials compare dialofloxacin to vancomycin plus aztreonam. The aztreonam could be discontinued once baseline cultures did not reveal gram-negative organisms. The two trials differed in that one investigated IV dialofloxacin only, and the other investigated a switch from IV dialofloxacin to PO dialofloxacin after 6 doses. The primary endpoint of both studies was a greater than 20% reduction in erythema at 48 to 72 hours in the intention to treat population. Both studies demonstrated non-inferiority of dialofloxacin to vancomycin for the primary endpoint. In terms of efficacy against MRSA infections, the first PROCEED study had 66% of isolates growing Staph aureus, with MRSA accounting for 52% of these Staph aureus isolates. And the second PROCEED study had 58% of isolates growing Staph aureus, with MRSA accounting for 36% of Staph aureus isolates. Clinical cure, defined as no remaining signs or symptoms at day 14, were similar between the two groups for these MRSA isolates. Additional phase 3 studies in community-acquired bacterial pneumonia has been completed and are currently pending report of results. Some of the advantages of dialofloxacin is the option to switch from IV to PO. It also offers a single agent that provides broad spectrum coverage from MRSA to Pseudomonas, which can be helpful in polymicrobial infections such as diabetic foot infections. Based on available data, dialofloxacin may avoid QTC prolongation, which can be a major deterrent to using fluoroquinolones. Some disadvantages is that it is a fluoroquinolone and therefore comes with a myriad of warnings with this class of antibiotics. In terms of antimicrobial stewardship, the broad activity limits its place in therapy in isolated gram-positive infections. Also noting the percent susceptibilities reported in studies, it may be prudent to confirm susceptibility of dialofloxacin prior to use in definitive therapy. The second agent that has been recently approved is omadacycline, or Nuzyra. Omadacycline was approved in 2018 and is a tetracycline derived from minocycline. The novel modification within omadacycline allows it to overcome resistant mechanisms such as efflux and ribosomal protection that confers resistance against doxycycline and minocycline. It is available as IV and PO formulations. It is FDA approved for both community-acquired bacterial pneumonia as well as acute bacterial skin and skin structure infections. Note that the IV and PO dosing are different, and both formulations require a loading dose. Also, there are specific oral administration counseling points for patients. So oral omadacycline must be taken on an empty stomach. Patients must fast for at least 4 hours prior to administration, and no food or drink is allowed 2 hours after administration. Omadacycline carries the typical tetracycline warnings regarding tooth discoloration and inhibition of bone growth. It has the additional warning regarding a mortality imbalance seen in patients with community-acquired bacterial pneumonia. The most common adverse effects include gastrointestinal effects, but also others that may require monitoring, such as increase in liver function tests. Omadacycline is notably active against MRSA and MSSA, or methicillin-susceptible Staph aureus, as well as Enterococcus faecium and Enterococcus faecalis. Omadacycline's gram-negative coverage is not as robust as zelafloxacin, mainly due to its lack of activity against Proteus and Pseudomonas. Note the yellow in the chart means potentially active, whereas it is active against E. coli and Klebsiella in the Enterobacteriaceae family, however, is not active against Proteus in the Enterobacteriaceae family. However, it does have activity against respiratory gram-negatives such as H. influenza and M. catarrhalis. It also has activity against atypicals and anaerobes. The two phase 3 clinical trials that led to omadacycline's acute bacterial skin and skin structure infection indication are OASIS 1 and 2. As previously mentioned, these studies are non-inferiority studies. OASIS 1 and 2 compared omadacycline to linezolid, with OASIS 1 providing the option to switch to PO after 3 days versus OASIS 2 compared PO omadacycline to PO linezolid. Mean days of total therapy was 8 to 10 days. An integrated analysis of both OASIS 1 and 2 found non-inferiority of omadacycline compared to linezolid for the primary endpoint, which is decrease in lesion size at 48 to 72 hours. Additionally, in the subgroup analysis of MRSA infections, omadacycline had similar rates of decrease in lesion size at 48 to 72 hours compared to linezolid. There was, however, a difference in rate of adverse effects with omadacycline, which had higher rates of nausea and vomiting when compared to linezolid. The higher rates of nausea was also found in OASIS 2 when the oral omadacycline was studied compared to OASIS 1. As for the FDA approval indication for community-acquired bacterial pneumonia, a phase 3 double-blind non-inferiority study was conducted. OPTIC trial compared omadacycline to moxifloxacin with an option to switch to oral agents after 3 days for a total course of 7 to 14 days of therapy. The mean duration of IV therapy in this study was 5.7 days, and the mean total duration of therapy was 9.6 days in each group. Omadacycline was found to be non-inferior to moxifloxacin for the primary endpoint, which was early clinical response defined as survival with improvement of 2 or more symptoms without worsening of other symptoms at 72 to 120 hours. Adverse effects were comparable between the two groups, except there was a slightly higher rate of diarrhea in the moxifloxacin group. In regards to the warning of mortality imbalance in patients with community-acquired bacterial pneumonia, in the OPTIC trial, the mortality rate was 2.1% in the omadacycline group compared with 1% in the moxifloxacin group. But the cause of this mortality imbalance was not established. Some of the advantages of omadacycline is it does have an option to switch from IV to PO formulations. It is also not a fluoroquinolone and therefore does not carry the slew of warnings that comes with fluoroquinolones. Notably, in the OPTIC study, no patients in the omadacycline group reported C. difficile infection, compared to 2.1% of patients in the moxifloxacin group reporting C. difficile infection. Some disadvantages include the fact that the PO administration can be very difficult for patients, and the PO formulation may be more difficult to tolerate. Additionally, we should take into account the mortality imbalance in community-acquired bacterial pneumonia found in the OPTIC trial. Mortality rates found were overall consistent with the expected range in other phase 3 community-acquired bacterial pneumonia trials. And notably, all patients who died in OPTIC trial were greater than 65, and the causes of death include progression of underlying pneumonia, hospital-acquired pneumonia, and also cardiac and vascular events. Notably, the mortality rates among patients who had a pneumonia severity index risk class of 4 were 5.9% in the omadacycline group versus 1.7% in the moxifloxacin group. However, this study was not designed to determine the statistical significance of these mortality findings. Lefamulin will be the first of 2 agents in the pipeline that I will review today. Lefamulin has been submitted for FDA NDA this year. It is a part of a new class called pleuromutilins. It acts at the 50S ribosomal subunit and is available IV and PO. Note the different dosing. Lefamulin activity is unaffected by resistance mechanisms to many of our currently used antibiotics, such as beta-lactams, and achieves high concentrations in the lung and skeletal and adipose tissue. Lefamulin has greater gram-positive activity compared to gram-negative activity, and notably lacks activity against E. faecalis. Additional coverage provided by lefamulin includes atypicals and respiratory gram-negatives. 2 phase 3 studies have been conducted for lefamulin for the indication of community-acquired bacterial pneumonia, with LEAP-1 comparing lefamulin to moxifloxacin plus linezolid if MRSA is suspected. The linezolid was discontinued if the baseline culture did not confirm MRSA. With the LEAP-1 provided the option to switch to PO therapy after 3 days. LEAP-2 compared PO lefamulin to PO moxifloxacin. Lefamulin demonstrated non-inferiority with a margin of 10% in both studies for the primary endpoint of test of cure and comparable rates of clinical response at test of cure. Test of cure is defined as 5 to 10 days after the last study drug dose. There is additionally a phase 2 trial for the indication of acute bacterial skin and skin structure infection, comparing lefamulin to vancomycin, showing comparable rates of clinical success at test of cure, here defined as 7 to 14 days after treatment. The main adverse events reported in the studies included gastrointestinal effects and infusion site phlebitis. Notably, LEAP-2 had higher rates of diarrhea in the lefamulin group compared to moxifloxacin. Some of the advantages of lefamulin is its novel mechanism of action, and therefore may remain active against organisms not active against current available antibiotics. It is a non-fluoroquinolone and is available at both IV and PO. It also offers a more narrow spectrum agent compared to the 2 MRSA active antibiotics that have been recently approved, delafloxacin and omadacycline. Some disadvantages are the potential infusion site pain and phlebitis that has been shown in studies, and the overall limited experience. Therefore, it is unknown if there are more serious side effects until it is further studied. Also a reminder that it does not have activity against Enterococcus faecalis. Lastly, I will be discussing icloprim, which is another gram-positive agent in the pipeline. The NDA for icloprim has been submitted late last year. It is a selective and potent dihydrofolate reductase inhibitor. It is in the same class as trimethoprim. The IV formulation is currently being studied, and a PO formulation is in development. And the potent activity of icloprim allows it to retain activity against trimethoprim-resistant dihydrofolate reductase organisms. It also achieves high concentrations in skin and skin structure, as well as in lung compartments. Similar to lefamulin, it has greater gram-positive activity compared to gram-negative activity, and notably different from is that icloprim has potential activity against Enterococcus faecium and is active against E. faecalis as well. Icloprim does have activity against respiratory gram-negatives. The two phase 3 trials for icloprim are REVIVE 1 and 2, both non-inferiority studies with a margin of 10%. The trials compared icloprim IV to vancomycin IV for the treatment of acute bacterial skin and skin structure infections. The pooled analysis of these two phase 3 trials found icloprim to be non-inferior to vancomycin for the primary endpoint of decrease in lesion size and for the secondary endpoint of clinical cure at 7 to 14 days. Subgroup analysis showed non-inferiority for decrease in lesion size and a margin of 10% for MRSA and MSSA infections. In Streptococcus pyogenes infection, there was a decrease in lesion size that favored icloprim. However, the sample size was relatively small. There previously were two phase 3 studies that compared icloprim to linezolid for complicated skin and skin structure infections with a primary endpoint of clinical cure or resolution of all signs and symptoms present at baseline. One of these two phase 3 studies did not meet non-inferiority when utilizing the 10% non-inferiority margin. However, the other one did meet non-inferiority. Reviewing the adverse effects of icloprim, the most common adverse effects were gastrointestinal effects such as nausea and vomiting. And note that there was no nephrotoxicity when studied in the two previous phase 3 trials. Additional consideration for icloprim was that studies found increased risk for QTc prolongation associated with higher peaks. One patient from the icloprim group from each of the two phase 3 REVIVE studies had a corrective QT interval of greater than 500 milliseconds. Both patients with these prolonged QT intervals had resolved to baseline after the end of the icloprim infusion. Some of the advantages to icloprim is that, similar to lefamulin, it has a narrower spectrum with mainly gram-positive coverage, which makes it more stewardship-friendly. It is also bactericidal, which differs from other gram-positive agents such as linezolid. However, at least one phase 3 trial demonstrated inferiority of icloprim when compared to linezolid, something to keep in mind when deciding between agents. There's generally limited experience with this agent, and it really requires more studies to be conducted in order to demonstrate regular use of icloprim in practice. In closing, we have enjoyed providing this webinar for the North Carolina Association of Pharmacists. We hope you have found the content to be informative. To receive continuing education, please follow the instructions provided for this webinar on the NCAP website. Thank you for your participation.